Do you need permissions? You got it? Perfect.
I got it. There we go. Cool. Well, hello, everybody. I'm Beth Pitel. I'm a clinical variant scientist at Mayo Clinic working in the genomics labs, specifically with oncology. And today we're going to kind of resurrect this topic that we had brought to this group back last fall. And we're excited with some of the progress that we've kind of made in planning for this group and really looking forward to hitting the ground running. I know there are several of you, even some of you on this call, that had expressed interest in being part of this complex variant group. And I'm excited to say that I believe that we're very close to formally getting started with this work. So thank you for your patience with just trying to lay the groundwork before getting moving with it. So with that, I'm going to present on determining best practices for complex variants. So first, we'll kind of go into some of the problems in describing and cataloging complex variants. For the purpose of this talk, we'll be limiting that to copy number variants, structural variants, and a little bit of copy neutral LOH and the combination of those elements. We all know that complex variants can be a number of different things and a number of different variant types occurring in a single event. So we need to understand before we get started what guidelines have already been established and what is the current landscape of work happening. And so back in 2019, there were some standards published collaboratively between CGC and ACMG for the reporting of somatic copy number variants and copy neutral LOH. So we'll review that paper, and then also quickly review some of the work that's being done in CLINGEN for hereditary findings, kind of covering a very similar topic here. And then finally, we'll talk about kind of the goals that we're thinking of for this complex variant working group. And I'd like to gather some feedback from this group as well, kind of based on some of the notes that we have and gauge interest of our different veins of this work. So I probably don't have to tell this group, but structural variants can look different based on what level we are looking at them. So we could look at the same variant in the same tumor with different assays looking at DNA, RNA, or protein and see very different things. And then other confounding factors might be things like tumor purity or the resolution of your assay. And so if you see an inversion that's creating a fusion that results in the activation of an oncogene, you might see multiple different things based on the layer at which you're looking at it. So that, in a nutshell, is one of the biggest problems in trying to annotate these complex variants is understanding how do we crosstalk or correlate between those different assays. And then this is a slide I stole from Dr. Chen Wang. He's been kind of my co-champion of this group. He is an associate professor here at Mayo Clinic, working with the clinical genomic sequencing laboratory in bioinformatics. And so he put this together, and it's just illustrating the fact that complex structural variants can be a combination of things. So copy number variation, structural variation, loss of heterozygosity, and the tumors that we're using, or the tumors that we're looking at can be very, very abnormal. And so understanding these complex variants and these different signatures that arise from complex variants can be important, and we haven't yet tapped that potential. Additionally, another problem that we run into is the ontology that we use to describe structural variants and complex variants is largely based on the technology used and the resolution that we're able to achieve. So it's difficult sometimes to correlate NGS findings with, let's say, cytogenetics, where in conventional chromosomes, we'll use a chromosome number, chromosome band, and ISCN nomenclature to describe those events. And then with FISH, with the same event, we might be describing enumeration or dosage, a break apart probe or a dual fusion probe, again, with the ISCN nomenclature. With microarray, we're using SNP coordinates, not to be confused with precise coordinates that we would use with the NGS or PCR-based assay. And then with NGS and PCR, generally we're using HGBS nomenclature or a C.P.G. type format. And so integrating the description of multiple smaller events in the same genomic events is hard to do. And complex events are super common in cancer and not always understood. And even if one element is well understood, the elements that are part of that same event, those passenger elements may not be well understood. Along with that, sometimes complex events are very hard to describe in a readable format. So here are two very different examples of events that, I mean, they're not the most the first presentation involving chromosomes 1, 5, and 12 detected by mate pair sequencing. So trying to describe with all the chromosomes and breakpoints on what is happening here was difficult to do. And then on the right-hand side, we have VCF content for 3 different CNV events detected in a breast cancer cell line by a bioinformatics calling algorithm. So neither of these I would really call human readable. And so what that results in, and this is probably my favorite figure of all time, is this bottleneck seems to get a lot more narrow when you have to do more manual work to understand a variant, both from the technical piece and from the interpretation piece. So being able to correlate results and find the evidence that is not cataloged as neatly as, let's say, a common CN or a common SNV, it can be a lot more challenging and time consuming. So some of the needs that we've defined here are we need to have readable nomenclature, a common data model where we can query and reuse data for CNVs, SVs, and complex data, and knowledge representation, all things that have potential that we haven't yet achieved. So next, I want to talk a little bit about what we do know right now. And so we'll review this paper quickly. This is the copy number variant and loss of heterozygosity standards that were published in 2019 by McHale et al. And this was a collaboration, like I said before, between the Cancer Genomics Consortium, or CGC, and the American College of Medical Genetics and Genomics, ACMG. And they came up with some recommendations and standards for reporting somatic copy number abnormalities and copy neutral loss of heterozygosity. So there are 5 goals outlined in this paper. First is the standardization of terms used to describe single variants or patterns of variants described by chromosomal microarray. And the use of chromosomal microarray, I think, is pretty strategic here. It wasn't just that everybody was using chromosomal microarray, but chromosomal microarray tends to be kind of a bridge technique between conventional cytogenetics. So chromosomal microarray does use a cytoband in their nomenclature, but they also use a coordinate structure, which is more readily accessible and relatable to NGS. So using chromosomal microarray, although it is a common technique, is also, I think, strategically smart here. So this was one of the goals of this group, and they have a very long list of, what terms should be used when talking about somatic variants. So instead of like absence of heterozygosity, which should be reserved for hereditary findings, we should use loss of heterozygosity. Things like that are all defined in this paper. Also in this paper, they provide a 4-tier evidence-based categorization system for acquired copy number aberrations and copy neutral LOH. And so this is somewhat similar to the AMP ASCO-CAP guidelines infrastructure or tier system. And even down to the color scheme in the figure, which you'll see in a little bit, is very, it's intuitive if you're used to working within that AMP ASCO-CAP structure. They provide examples of tier 1 and 2 variants and various neoplasms. And then I think some of the most helpful work that came out of this was listing out those considerations regarding the interpretation and reporting of these variants. And then, considerations for interpretation and reporting of not just the somatic variants, but also significant germline variants that we might find in these patients as well, because oftentimes we're only assaying the tumor sample. Sometimes we have a tumor and a normal sample, and we're able to ascertain exactly what a germline finding is. Other times we're more or less using the tools that we have at hand to make our best guess at what might be germline. And then finally, this group attempted to create a framework to standardize the clinical reporting of acquired copy number alterations and loss of heterozygosity. So as I said before, here's the tier classification. It's very similar to AMP ASCO-CAP. However, there are considerations that need to be taken into account for CNVs and copy neutral LOH. So acquired variants and variant patterns, for that matter, that define a specific disease state or entity in WHO or professional guidelines would be a tier 1A. Tier 1B is something that has good quality evidence and has clinical relevance within that specific neoplasm. And then tier 2, similar to AMP ASCO-CAP, is a little less specific to the cancer type. So you have recurrent acquired variants observed in different neoplasms, but not necessarily specific to this tumor, that have some diagnostic, prognostic, and therapeutic significance. And then acquired variants with a specific neoplasm shown with a lesser evidence score. And so the evidence scores are defined in here as well. Tier 3 is a VUS, tier 4 are benign variants. They're things that are known benign germline. So some considerations in reporting I thought I'd highlight here were that interpretation of CNVs and copy neutral LOH should be within the disease context and in the context of other relevant laboratory tests. So this kind of goes along with one of our challenges in correlating these results. Copy neutral LOH segments have higher clinical significance if they span an oncogene or cancer gene with a known pathogenic SNV. So that's something that might be able to kind of bump us up in the tier system. And then you can use the tier system to classify patterns of copy number alterations. For example, a 1p19q co-deleted regions in an oligodendroglioma. That's diagnostic, so that would be a tier 1A. Another consideration is balanced rearrangements. With microarray, we don't see those, and so we can state that we saw them in another test in the report, but we should not be defining a tier for those. Interstitial copy number variants and multiple terminal CNVs may result in fusions and can be interpreted within this tier system if the breakpoints are known and well defined. Some common examples of the interstitial CNVs would be like a FGFR1 TAC1 fusion, or like KIAA 1549 BRAF fusion that we see in pilocytic astrocytomas. And then just every so often, we will see two terminal CNVs, usually one gain, one loss, and we're able to see the genes that are right at the breakpoint and make our best guess, confirm that a fusion has occurred between those two partner genes. And if we're able to do that, we often report those out as well. LOH can be observed both at a neutral copy number state. We see that a lot with genes like TP53, RB1, or a copy number gain. So something to keep in mind when we're correlating NGS results with LOH is if we see LOH in an amplified region like EGFR or MYC, how are we going to interpret that? So all things that are important to think about and consider when we're looking at, not just one technology, but multiple technologies, multiple variant types that operate together. Another thing to consider are potential comorbidities. I know that in our practice, sometimes we see low levels of hematologic malignancies with our solid tumors as well. And so understanding that that can happen. As I mentioned before, there is a group at CLINGEN that is doing some similar work as well. It's a hereditary genetics group, and they're creating an evidence-based clinical classification for reporting across laboratories for CNVs. So they're creating scoring metrics, standardization of reporting, using the same terms that we use for pathogenicity of SNVs for that group, so pathogenic to benign, and these changes ultimately improve patient care. So this work is ongoing for them. CLINGEN CNVs, they have specific reporting criteria that they're including cytogenetic location, CNV size and genomic coordinates, the copy number state, and then just expectations for nomenclature depending on the assay that's used, and use of the dosage sensitivity in CLINGEN. Additionally, cancer variants have additional nuances, and so we may not know the exact copy number of the alteration that we're looking at, even if we're looking at CNV data, depending on, because a lot of times that depends on things like ploidy. Subclonal variants are often present in tumors. They may not be in 100% of our tumor population. Tumor purity is a confounding factor for CNVs, as well as other variants. And then there are dosage rules in the evidence about specific genes. So I would interpret a 2.5x fold change in ERBB2 quite differently than a 2.5x fold change in in MYC in something that's 100% tumor. So it can be very different. And then there are disease specific dosage rules that we can find in evidence as well. So I'm glad we're getting to this so quickly. Jen and I have been working on creating this charter for the working group. I was on family leave a little earlier this year, and he continued working on kind of fostering this collaboration with a group called AMIA. They're the American Medical Informatics Association, and AMIA has endorsed this goal of creating this group in collaboration with VICC. And so what we're proposing is to start with a literature review based on member expertise, followed closely by a review article on gaps and recommendations from the working group on how to deal with complex variants. And we've suggested some subspecialties, but I wanted to bring this to VICC and have kind of a discussion on what does this group feel would be appropriate subspecialties. Are there things that we're missing, or did we do just such a good job in coming up with our 5 subspecialties? So here's what we're proposing for our literature review. First, we want to delve into CNV and SB context representation, so nomenclature and representation of breakpoints and or junctions and dosage. Secondly, requirements for metadata. The question is, would this be similar to SNV, or would this be a little different? Because CNVs, SBs are inherently a little different than SNVs. And then how do we translate the results from copy number variants and structural variants, complex variants between tests? So what are resolutions of specific tests, and what are the technical limitations between assays, and different challenges we might have in kind of seeing the same variant across different assays? This 4th group, I think, is really interesting. It's the translational use of CNV burden or a structural variant burden or signature scores relative to an HRD status. So in some of the literature now, we see things like CNV burden. So what percentage of the genome is at an aberrant copy level? And how does that correlate to things like, HRD status, response to PARP inhibitors or immunotherapy, just understanding what that means a little bit better. And then 5th here, we have current status and barriers of reusing copy number variants and structural variant data for real world data and real world evidence generation. And I think this was a point that was brought up by the AMIA group that we thought was so good that we added it here too. So just some additional notes about translational significance. This is a slide from Chen as well. So this is CNV burden scores that have been defining HRD status. And so there are a couple of reports correlating CNV burden with the HRD status and associating that with BRCA-ness and response to like DNA damage therapy. And then also there's another paper here this is another slide from Chen. This is talking about tumor aneuploidy correlating with markers of immune evasion and response to immunotherapy. So you can see ovarian cancer is very rearranged and has a very aberrant copy number state. And I think a lot of us know that if we're looking at microarrays, if we see a high-grade ovarian tumor, a lot of times it's very abnormal and has a lot of different copy number states, a lot of different breakpoints. So how does that correlate with immune response and all of the different signatures that we can associate with copy number status? So with that, I know I gave Wes a little poll to give you all quick, and then I thought we could have a really good discussion about what else we can do with this group proposal.
I posted the poll in the chat. Since this is Alex's Zoom and I don't host it, I can't do it. So I made a separate poll that we can follow.
I'm going to go ahead and start with a question.
Sounds good.
So Beth, I think in our, and Wes probably can attest to that as well, in our clinical world, I think what we struggle with the most is that, you know, in order to derive complex copy number information from exome sequencing, you kind of have to break up the genome and then put it back together, and then, you know, hope that you can still really translate what's going on. Whereas, and my disclaimer is that I really think that cytogenetics provide a really beautiful 30,000 feet view of a genome of a cell, right? We are having a hard time from exome sequencing, deriving copy number, is really understanding ploidy, understanding subclonality, and putting it all together. I think those kind of challenges, it would be really great. And I know Gordon and I have had these conversations many times. And in fact, we're in a work group at ACMG to address specifically that. But in your initiative, which I think is amazing, is there any chance that you can also address these challenges? Because I'm concerned that the world is deriving copy number from exome sequencing or genome sequencing. It's just not the same. We really don't know what is going on a single cell level, right? We don't know what the genome looks like before we break it up, we put it back together. Does that make sense?
Yes, and really that's how we know about most of these subclonal findings, right? Because we're able to see them in, you know, fish or karyotype. And there's not a whole lot of clinical labs that are doing, you know, long range single cell sequencing. So I think that's all part of the big picture. And so I completely agree with you there. Do you think that fits neatly into any of these? I'm trying to think if this fits neatly into a subspecialty here. I guess maybe concordance between assays and then making sure that we cover cytogenetics sufficiently.
Yes, that's exactly what I'm really trying to propose or advise on. I think just the awareness that what we derive using the information that we derive using different methodologies may be different. And the secret is to know exactly what are you missing, right? Like ploidy, I mean, when you normalize the copy number data, you're playing with ploidy without really knowing whether this is a haploid or a triploid or tetraploid, because you normalize it based on different kind of information, right? Just the awareness of this, really, then we understand what the limitations of the results are.
Great. Cool, thank you. Looks like we have some poll results. So Feel free to keep voting if you'd like. Looks like SNB or CNV and SB concordance between assays and translational use of copy number or structural variant burden and HRD are kind of our front runners for interest, but excited to see that 4 of the 5 have interest here. Oh, I see there's some hands raised. Sorry. Manuela.
Yeah, thanks for putting together this working group. I think this is really important nowadays. And I mean, what Yasmin just said goes also together is how do we represent this if it comes from different techniques? Is there a chance that you have like a very complex variant which has been supported by different techniques is more relevant than other ones? Is that already part of the tiers in the original?
It's not part of the current tiers. Like the CNV tiers that were put together by CGC were specifically for variants seen by microarray data, but I wonder if that's something we could look into, kind of giving a little bit more weight to variants that have been identified and functionally characterized in more than one way.
And it's what sometimes happens that if you see it in NGS that you're actually asked to verify and validate using another technique before you actually propose something or working on it.
Right. Yeah, we do that all the time in lab practice. So we have a lot of like digital droplet digital PCR assays or like de novo fusion assays that we'll make up on the fly to confirm novel findings. Thanks. Gordana.
Yeah, so I have a question about the terminology maybe or the name of the working group. I think it's a great initiative. I'm just thinking that talking about complex variants is a little vague, and it will be hard for people to understand what the scope is. Complex variants will mean something very different to different people. If I'm a molecular pathologist, I might think that a complex variant is deletion insertion of base pairs. You know, the one that you have deletion of some bases and insertion of others. I will think of that as a complex variant, or something like tumor mutational burden, or it would be a complex marker. Or so I'm just thinking if we could come up with something that will be more concrete and it will better reflect what the scope of this working group is. So just a comment. I don't know if it's solvable, but I just think that complex is so vague. The other point is that we lose the term structural variant so loosely. And we were going back and forth between copy number abnormality, structural variant. For example, I would like to ask cytogeneticists in the group a question: would you call interstitial deletion structural variant or not? Would you call unbalanced rearrangement a structural variant or not? And that's at the same time that copy number and structural variants. So we need some better definitions around those terms. Structural, what do we call it, structural variant? So I think that just even as a starting point, some clarity about terminology is good, because if we communicate clearly, we'll be thinking more clearly. That's just my point.
I totally agree with Gordana. I really do. I rarely disagree with Gordana anyway. Let's put it out there.
Thank you, Yasmin. I know we think about these things kind of we are on the same page about these things.
Totally. Yeah, I think it's really great. It would be better to define complex. Complex to this group may mean very differently to somebody else, and we want to communicate it, better. Yeah, I mean, Gordana, to answer your question, I agree with you. I think anything that is copy number alterations, to me, they're copy number. Anything that is balanced and structural is structural. but that is how I think about it. And I agree, there isn't really a consensus. And perhaps this is
There's no consensus, and we think we have to rethink these terms and define them better as a community.
Yeah.
Because now it's very chaotic, and it didn't used to be such a problem, but now that we are deriving copy number variants and balancing arrangements for sequencing. I mean, when we were just doing it from karyotype, I think cytogeneticists had their way of using these things and some clarity around it, but now it became completely all over the place. So I think defining it as a community would be a good first or early step in the whole process.
Yeah, thank you. And I think that's something that, Chen and I were talking about a lot, but we weren't really talking about complexity at the nucleotide level necessarily. But then when we started talking a little bit more, we started adding it back in.
Yeah, but somebody will think that when you say complex variant, that you're thinking genomic complexity, that you're restricting this to chromotripsis and complex genomes like autism, right? So there's so many ways to understand the term complex variant that if we could come up with something more concrete, that I think would go a long way.
Okay. Yeah, we will definitely, maybe that's the first step for this working group, like define the scope of what we're going to start with and then move from there. And I think if we're talking about kind of keeping the cytogenetics piece kind of relevant, I could see unbalanced, balanced copy number variants, like all being relevant. And then being able to like interpret that in the context of sequence variants, splice site variants, things like that too. So it's, yeah, it starts off complex. Well, thank you. Are there any other thoughts, comments, suggestions?
But thank you so much. This is a great presentation. This is not a question, but just a comment. I'm very active in EMEA, and I'm probably, I mean, this working group will be great for us. I mean, we have a translational bioinformatics working group, but I think that's something we really needed in the EMEA, basically in the EMEA group. So I think that's great. And please let me know when the first meeting is, and I would love to be there. I assume that you guys haven't started the meetings yet, right? Because I haven't seen the working group in the list.
Right, yeah, we haven't started yet. We're trying to like complete really clear goals in the charter for VICC, and then I think we'll be good to go once we get approval from VICC leadership as a whole, and then we can get started. The thing I really like about EMEA, and I'm not sure everybody knows about it, but the working group goals are very concrete and set. So
yes,
the working groups only convene for about a year at a time. And so there's a defined like deadline for getting a paper written or getting projects wrapped up. So that's actually really, really helpful.
Yeah, you have to basically every year, every working group has to report back to the leadership, tell them what they've been working on, what their progress is. It's the same for the committees and subcommittees too. I'm very active in EMEA, and it's very structured. So I think it will be great. It will be great. Yeah, let me know when the approval is there and when the meetings start. I'm sure. I mean, I have a couple of colleagues at Brown. I'm sure they will be interested in joining too. Thank you.
Thank you so much. All right. Well, if there aren't any other questions, oh, I see there's some. Great, thanks, Wes. If there aren't any other questions, we can break a little early today, but if you have any comments or ideas, please feel free to email me or Chen. I think he's just wang.chen@mayo.edu. And yeah, we're really excited to get the ball rolling on this working group and to be collaborating with AMIA in this way as well. So thanks all for your attention, your enthusiasm around this, and please let me know if there's anything anything I can do. Awesome. Well, have a
Thanks
great
a lot,
day.
Beth.
Thank you.
Thanks a lot.
Thank you.
Thank you. Thank you.
Thank you.